Well, it is the top of the hour, so I think we should get started so we all have plenty of time for questions at the end. Good afternoon, and welcome to the fifth of our 9-part series on emergency planning. The session today will focus on health literacy and emergency preparedness ruling, or emergency preparedness planning, and why it matters. My name is Christy Fable, and I am a Quality Improvement Advisor with Superior Health Quality Alliance. I'll be facilitating today's call along with my colleagues, Allie Albers, Mike Bitten, and Tony Kettner. So before I introduce our speakers, I want to take this time to review just a few housekeeping items. We will post the slide deck several times into the chat box for your convenience, and it is already there for you. Please feel free to add questions and comments into the chat box as you think of them, and we will answer questions at the end of the call. There will also be an opportunity to ask a live question at the end of the call, and we'll review that process after our speakers. The series is being recorded and will be available on our YouTube channel in about 2 weeks. So this will allow you and your team to access the recordings on demand when it is convenient for you. We'll also post an evaluation link at the end of today's call, and we would appreciate it if you would take a few minutes to complete that evaluation for us, as we use the evaluations to improve calls and to determine if there are other topics you may find helpful. At this time, I would like to welcome our speakers once again, Brian Kaczmarski and Amy Woolman-Nesseth. Welcome, and thanks for being with us again today.
Thank you for the introduction, and good afternoon, everyone. Amy and I are glad to be back. I see that there are still people trickling in, and my take on when we do series like these that extend over a period of time, I'm just glad people come back. You know, the evaluation and what they say and things like that, that's all just cherry on top. But I'm just glad there's people here. So thank you very much for that. As we jump into today's session, health literacy is, to be honest with you, not a topic that is often associated with emergency preparedness. And Amy and I were very intentional about including this topic because hopefully we can give you some ideas and examples of why we think it should be a topic that is intimately related to preparedness. We're going to show you some examples of some materials that are already out there. One of the golden rules in preparedness is you should never need to create something from scratch. Something already out there exists. You just need to borrow it, usually tweak it to meet either your agency needs or the needs of the incident that you're going through. But if you do a review of many of those materials and resources that are out there right now, you're going to find that they're not health literate. And you may actually be doing more damage to your response in your agency than had you not been conscious of that. And then we're also going to talk about, since there are some complicated resources out there right now, we're going to provide some examples of some best practices and tools and resources that are out there that will help you take those tools and bring them down to a more health literate level. Next slide, please. So health literacy, we really think about this from a global perspective, and then we break it into 2 further areas. So health literacy itself is finding, understanding, and using information, and then making, from our perspective, making that information findable, understandable, and usable. So it's not so much about a person's health, it's about the information that we're getting to them or making available to them, and they understand it to the extent that they can make thoughtful decisions that will impact their own health or the health of their family, friends, or loved ones. So to that extent, organizational health literacy is the degree to which we look at that concept and try to make the tools and resources and press releases and any information that's going out to either our patients, our families, the communities, the partners that we work with, really being intentional about making it as understandable as possible, which then leads to personal health literacy, which is the degree to which people can find, understand, and use that information. And here's the key: to inform health-related decisions and actions for themselves and others. The reality is what we're doing is we're not giving a play-by-play of whatever might be happening in the incident. We're trying to guide public decisions so that they make proactive, health-conscious decisions for themselves. That's the concept of health literacy. Next slide. So even in an emergency, obviously the planning needs to take place beforehand. There can be just-in-time health literacy reviews of materials and documents that go out there. But here's just a few examples of why it's important to keep our target audiences as understanding and knowledgeable of our activities and our actions during an event so that they can proactively help themselves. So from an example of a big bad thing happening, if we're health literate and proactive enough in our preparedness, our public is going to understand how to respond to an evacuation should that incident arise. That's just one example. They're going to get their own preventative care, such as staying up to date on vaccines for infections and illnesses. And the reality is, if we do a good job in preparedness of getting people to understand that concept and really take it to heart, we are mitigating the potential impact of a future outbreak. That is a preparedness task. We want people to avoid hazards such as carbon monoxide poisoning. You always hear the ice storm is coming. We know that there's going to be long-term power outages, and you always hear one or two headlines of a family passed away or became severely ill because they tried to heat their house inappropriately. And again, if we're preemptive about our messaging and can get it to those individuals in a clear, understandable format, hopefully we can mitigate or prevent those types of tragedies. And even managing a chronic disease. One of the things that Amy and I see often, and really is a common theme, anytime there's a shelter situation, the biggest issue that we see for people coming into shelters, they didn't bring their meds with them. The meds that they need to maintain their daily health levels so that they can function when they're away from home. That ends up being the biggest issue. So we need to think about that from a messaging perspective. Who and how can we get that information to people so that we have to deal with less of those types of situations than we would have. Next slide. So an example of health literacy happened, several examples happened during the COVID pandemic. You probably heard the term social distancing. You probably wake up with nightmares of that term, but especially early on, the message across all forms of media was social distancing. And it didn't take long to figure out that people simply didn't understand what that term meant. And so the CDC, about a month or two into the pandemic, they took a different approach. All of a sudden, their messaging, their social media posts started to go to a plain English or plain language approach. And instead of using social distancing, they just changed all of their messaging to say, stay 6 feet away from people. And you started to see the signs with the number 6 foot and little figures of humans with the arrow in between and 6 foot. And all of a sudden, the level of understanding and compliance with social distancing dramatically increased because of that. So that's just one example.
So I don't know how many of you have worked in a hospital setting before, but when I first started as a chaplain in the hospital, when you go through orientation at the time that I was starting, you got a whole list, a card that actually went on the back of your name badge that had code white equals this, code pink equals this, code gray equals this. And eventually there was a movement to move away from those kind of code languages to go to plain language. And there were lots of reasons for that. One would be if all of a sudden there was an alert to code gray, instead of staff responding quickly, you saw everybody stopping and looking at the back of their name badges as they couldn't remember what a code gray was. So it delayed response. It also prevented people that were within the organization, whether it was staff or visitors or volunteers, from responding to the incident. So for example, a code pink in the hospital I worked at, that meant that there was a missing infant. And instead of everybody, and everybody meaning the volunteers, the staff, the visitors, the family, everybody that was in the organization, knowing that they should be looking, it was only the select few that understood what a code pink was who really went into action. As soon as they changed that to plain language, all of a sudden you've exponentially increased the number of people who could be on the alert, watching for someone with suspicious activity or walking out the door with an infant. So plain language is super important. What are some of the common barriers to that plain language? We all know that living and working in a hospital setting, a healthcare setting, we have all sorts of jargon and medical words and abbreviations that most people don't understand. But we throw them around all the time as staff members. We also know that the system of healthcare is a different animal as well. And so when people come into the healthcare system, it takes a while to understand the flow, the processes, who makes decisions, how decisions are made, et cetera. Being able to communicate with healthcare providers. A lot of our healthcare providers are not English speakers as their first language. And so heavy accents or speaking quickly or any number of things can be a barrier. Finding information, again, that concept of literacy and being able to be technically savvy. It's not easy to just ask someone to go log onto their computer and know exactly what words to search for or how to find the information that they're looking for. When I worked as a chaplain, I found that one of my primary roles was to serve as that interpreter or navigator or guide to the healthcare system. Now, I was not a true interpreter in terms of being able to translate language from Spanish into English or vice versa, but I still had to walk with families, walk with patients to help them understand what the doctor meant by that, or to get that doctor back in the room, back in the care conference, to slow down and to actually take the time to explain what the acronyms meant or what the procedure meant. Another really great example of that was when I was deployed as a Red Cross disaster spiritual care provider, and we had what was called the Multi-Agency Resource Center. It was a huge building where people that had been impacted by the tornado could come and visit a whole bunch of different vendors at once. So there were insurance companies, and there were people from FEMA, and there were people from the cell phone companies and all of that. But in order to get services, the people that came to the mark had to fill out a form. And I was one of the volunteers that was assigned to that multi-agency resource center for the day. And we had more than one individual come through, look at us, and not be able to complete that form. One, they couldn't read. B, or number two, they were so traumatized by the events that had happened that they simply were too scattered. They couldn't sit down and focus on this particular form. And it took, paying attention to the cues, listening and exploring what those barriers could be to be able to figure out how to help people just fill out the form so they could access the resources. So I think sometimes, we make assumptions, right? I love reading. I read all the time. I've got 2-3 books going at one time, which really is not good for me. But so I often make assumptions that everybody else can read, right? And that is an inaccurate assumption. Not everybody reads at the same level. Not everybody can read. And I think we have to remember that there are many other limitations: culture, age, income, education, language, all of those things that contribute to this thing we call health literacy. So if you need justification, this is some of the research that Brian is so good at doing and finding. Nearly 9 out of 10 adults struggle to understand and how to use personal and public health information. And it's not because we aren't trying. It's because there's unfamiliar words, there's terminology that is difficult to grasp that we as healthcare providers take for granted. There is a cost to all of our organizations for not making sure that health literacy is a part of our program. It says that you could prevent 1 million hospital visits a year and save over 25 billion a year if we paid more attention to this. Now, I'm going to bring up an example that stuck with me, and I don't know why it has, but it's been 20 plus years now. If anybody ever watched ER, you know, with George Clooney and all of those wonderful Nurse Carol. Anyway, there was an episode about a woman that came into the emergency department. And the reason she came into the emergency department was because the label on her medication said that she should take her medicine once a day. But she was a Spanish speaker. And so once means once, which means 11. So instead of taking 1 pill, she took 11 pills, which resulted in a medical emergency. And so again, that's an example of how what we take for granted as easy instructions was misinterpreted and resulted in an emergency situation. I don't remember if she lived or died. I'm sure she lived, since it was nighttime TV. So we can also improve by using clear language, clear communication, familiar concepts, words, numbers, images. And then I think this is a point that Brian already made, but it is super important. If you are creating information that is designed for a particular audience, why are we not asking that audience to help us draft or create that message? Trial, test, make sure other people in the intended audience are able to review this information before we put it out to the public. We may save ourselves a whole lot of headache if we do that. A couple other things. One of the most important things that we all strive for in healthcare is trust. And if we communicate and take the time to make sure that our patients understand and our family members understand what it is that we're trying to communicate, that will build that trust. And that will help us in the long run. And now jargon, emergency preparedness folks are just as guilty as healthcare, right? We throw acronyms around, we're excellent at it. And we have to be very careful to slow down and recognize that we need to spell things out and not take for granted that everybody understands what an EOC means, all right? EOC stands for Emergency Operations Center. So again, we understand also the importance of translation, making sure we have appropriate interpreters, making sure, especially in the hospital setting where I worked in the emergency department or in the critical care unit, that we're not just using family members as interpreters, but that we have certified medical interpreters. Because sometimes that medical information, again, a family member may not know the terminology. And so how they interpret may not go smoothly. So all of those things help us as we try to create our health literacy publications.
Thanks, Amy. Just one example that I was able to pull, and this is out of a case study in, it was a Dutch case study. I'm sorry, I was losing my terminology there. Well, what they did is they did a review of social media during this event that happened at a Dutch chemical plant. And they used, I believe, Twitter as their platform, because that's what people were using to communicate back and forth, who were in close proximity to this disaster. And what they found is a clear lack of alignment between the disaster response. So the people, the lights and sirens, the healthcare people, the people that were responding to the big bad thing, and the public. And they identified 4 buckets, 4 common themes of concern where there were areas. Number one was the alert, the chemical incident itself. And what they found out is the public's perception of the alert of the chemical incident was that it was delayed. It was poo-pooed, meaning they felt that there wasn't enough emphasis behind the potential seriousness of the incident, based on the type of messaging that was going out. They felt that there was very poor or inadequate communication. And if you dig a little bit more into that report, it would say there weren't frequent enough reports. There weren't frequent enough updates. If you follow the media, they get in a cycle. When there's a big event that's happening, they get in what's called a reporting cycle. And the responders to an incident that are leading that incident and the ones that are behind the microphones and behind the television cameras, they will be very thoughtful about saying, our next report, our next briefing will be in 2 hours. And what that does is it allows the public to know what's coming down the road. And by avoiding that black hole, that void of information, by not knowing when the next update is coming, you are mitigating something called rumor control. You are mitigating the concept of misinformation. Even if at that 2-hour briefing, they say, we have no new information at this time. So studies have shown even that type of a scenario will bring the anxiety level of the public down, and it'll make it so that they don't start perceiving things that aren't there. The problematic disaster management itself, and then the insufficient disaster health literacy. So again, these people that were responding were either very into medical terminology, medical jargon, or they were engineers and experts that were tied to that particular plant. And they were talking in the terminology that they're used to living in, the world that they're used to living in. Public is not used to living in that world. Now, I know that many people that are on the call right now, we would consider ourselves in the healthcare field. So it may be difficult for us to comprehend a lack of health literacy because it's the world that we live in. I would offer up this scenario. Jump into the world of health insurance for a minute and let me know if you feel totally comfortable with the terminology and the literature that you read around health insurance. And if you're like me, I feel very uncomfortable in the world of health insurance because I don't understand all of the options and the way that the system works. That is one micro example of when we're responding to an incident and sending messaging out to the public, that's how our public feels. So we need to keep that in mind as we develop our messaging. Next slide. And then the last one I wanted to point out, and I thought this one was really relevant because it uses Google, and don't we all use Google? What they did is a meta-analysis of the top 50 hits off of Google when they were searching for information related to a disaster. So the researchers they typed in certain keywords about a disaster, a perceived disaster, and they looked at the top 50 hits. And what they determined using a couple tools called the Flesch-Kincaid scale, the Flesch Reading Ease scale, and the Suitability Assessment of Materials, or the SAM tool. Here's what they found on those top 50 hits. And remember, Joe Q Public is usually not going to drill down past those top 50 hits. This is the stuff that people are looking at. They found an average flesh Kincaid score of 10.74, goal being 5, almost twice as difficult as what is recommended. The FRE score, 45, suggesting difficult or hard to interpret, and the average SAM score, 48%, meaning not suitable for public consumption in terms of understanding or comprehending. They then went on to find out websites on pandemics and bioterrorism were the most difficult to read and the least suitable. And I find that ironic because most of the federal funding that we all receive starting in 2003 after 9/11, the program and the funding started out tied to bioterrorism events. And 20 some years later, we're still doing health literacy poorly in that initial focus area. Exciting.
So I put in the chat something that I think is really important. We're kind of brushing up against what's called crisis emergency risk communication. There is an actual course that's free. It's online and available at the Center for Disease Control website. It's called CIRC. And it's a really good class to help us understand if you have anybody that speaks with the media, any public information officers, how do we communicate to the public? So for example, oftentimes in an emergency, we want to tell people what not to do, right? But instead, what we should be doing is telling people what they should do. Do this, because otherwise people hear, just even if they hear a snippet, it may be that they miss the don't, but right before it. So we want to make sure that we're telling people exactly what we want them to do. And there's a whole bunch of other kind of rules of thumb that come with crisis emergency risk communication. It's an excellent topic and something that we could explore further down the road, perhaps. But that is a free resource available to anybody who's interested in more information. So the whole reason we're talking about this today is how does health literacy link up not only with the patients and the families that we care for, but how does it work with emergency preparedness and the people within our own organizations? Again, we tend to think about what we're publicizing, what we're putting out to the public, but we don't always think about our actual emergency preparedness plans themselves. And I would challenge you all to pull out your emergency operations plan, your EOP, and check it for medical jargon. Look at it for acronyms. Is there a way for people who are new to your organization? Maybe it's even acronyms that you use internally to identify certain parts of your building or different units within your department. If those aren't spelled out and I'm a new employee to your organization, would I know where to go or where to find certain resources? We also need to remember that if we have a very large event where we are dependent upon the fire department or the police department or EMS agencies to come into our building or to assist us, they also are not familiar with some of those jargony or acronyms or shortcuts that we sometimes make in our plans. So we have to, again, try to strive for plain language and make sure that anyone who looks at those documents from internal or external are able to find their way and understand the plan. And then there's a really important piece to this that's going to tie it all back to emergency management and emergency preparedness and CMS. And that is that it is a requirement in CMS, Appendix Z, to show your patients and families your preparedness response plans. So this is what it says. Page 78 of Appendix Z, which again is the interpretation guidelines of the CMS emergency preparedness ruling. Under tag E35, a method for sharing information from emergency plan. that the facility has determined is appropriate with residents or clients or patients, their families or representatives. So again, it's not telling you how you have to share this information or what information you have to share, but you are required to share emergency preparedness plans and policies. We would recommend that facilities provide a quick fact sheet or informational brochure about how you as an organization are prepared, what your fundamentals are for emergency preparedness. So there's a lot of subjectivity to this, but you may be asked by a surveyor to show us how you communicate to your patients and your families and your representatives regarding your emergency preparedness plan. So you have to be prepared to do that. And how you communicate that, again, should be done with an eye for health literacy. Brian.
Yeah, thank you, Amy. So if I had to summarize to this point, I would say we tend to focus on information that is external to our facility, the stuff that we're pushing out. What Amy really tried to emphasize on the last slide is you have a very complex, robust emergency operations plan that is internal to your facility. And one of the things that we tell people when we come in and do plan reviews is if we pulled somebody in off the street right now and had them read your section on standing up incident command, would they be able to muddle through it? And that's the mindset that you want to be looking at in terms of your emergency response plans. The disaster preparedness planner may not be there at the start of the event. That automatically puts you behind the 8 ball when that incident starts. The director of nursing, who is always focusing usually on the clinical aspect of day-to-day operations as well as emergency response, may be thrust into that role of incident commander during a response. And are they going to be able to muddle their way through the jargon of, for example, what are the trigger points for an evacuation? So some of the tools, some of the terminology that you're seeing on your screen right now are tools that you can run your plans through or up against that will help give you an analysis of the complexity of your plans and then give you ideas and recommendations on how to make them more health literate. And we're going to jump into each of them a little bit here. The one that you're seeing on the screen right now is called the CDC Clear Communication Index. And this is a snapshot of the website. And what it does is it allows you, by asking you a few questions and then assigning some scores to some certain areas, you can take a document or a section of your plan or an annex. On the flip side of that, you could take messaging that you're sending out to your public and your families and your patients and things like that, and you can run it through this, and it's going to output you a score, which is going to give you an idea of, are we on track with health literacy here? And if not, it's going to give you recommendations of how to make it better. So that is one resource. Next, Amy. This is the proposed literacy model that came out of a peer-reviewed journal with adults with physical, mental, and educational disabilities, so our most at-risk populations. Now, I pointed this out because, again, from a health equity standpoint, we owe it to these target audiences to do whatever we can to make the information that we're disseminating as understandable as possible. They have the same right to make self-informed, advocating decisions for the betterment of their health, just like everybody else does. The other thing that I want to mention is in times of emergency response, even the general public mental status becomes decreased. So we understand that during times of an event, the average American understands at a 5th grade reading level. Okay. And if the incident is truly impacting them, they may get something that is called tunnel vision in the preparedness world. So they're understanding and comprehending even at a lower level. So keep that in mind. And this model identifies lack of alignment between readability of current materials, things that are already on the web, versus the literacy skills of vulnerable subgroups, limits their ability to understand and effectively use potentially life-saving information. This is a health equity issue. There's no, it's not random that we see certain groups that are disproportionately impacted by disaster, because we're not giving them the tools to be able to make proactive decisions for themselves. And information and the understanding of that information is a tool. And that is part of our job within our emergency response plans. The takeaway from this model is exactly what Amy said. It's target groups, it's focus groups. As you're creating your tools and resources, reach out to the intended target audience. Have them peruse it. They will give you recommendations back. That gives you your second draft of whatever that model is, and then show it to them one more time. And you may be spot on and ready to disseminate your information. Next slide. The class standards. This is probably one of the most well-known. It's tied to a lot of regulations and oversight agencies, but the national standards for culturally and linguistically appropriate services in healthcare. If you are unaware of what this is, dig into it. There are 15 action steps that are identified. There's a very clear implementation guide. It does crosswalk to some accreditation standards and other performance measures that many of you may be held to. And it also talks about key moments where health equity really made a difference in events that have happened in the past. I would really recommend that the class standards be crosswalked with your current emergency response plans if they haven't already been done so. Next slide, please. Thank you. And then simply put, the link is right there, but it's a CDC guide. But what simply put is just a very simple, plain language guide for creating easy to understand materials. And again, when we're talking about materials, think internal and think external. And all of the tools that we just perused through can be used in both of those scenarios.
So, there really is an evolution to emergency planning and preparedness. Most of your emergency operations plans are going to be heavy on narrative. They're going to give some background to your situation. They're going to some history of your organization, perhaps. There's going to be a rationale and a purpose to why we write what we write in narrative form in your emergency operations plan. But when the big bad thing happens, how many of you are going to sit down and read a 3-page narrative document on how to do one particular task in emergency management? Nobody. Okay. And so even though we focus on the importance of having that emergency operations plan in written form, making sure that everybody within the organization knows where to find it, those are all very, very important things. But the reality is nobody is going to sit down and read a novel when they have to be taking very quick action. So the next step then is to take that emergency operations plan and to turn it into what we call operations checklists or field operations guides or standards of operations, creating a checklist so that in the first 2 hours of this incident, we are handed a job action sheet for the incident commander, and we have a checklist of you should be doing or thinking about these things. And it's a very simple guide then to get people through those initial actions. Because again, when we're under stress, our ability to think clearly diminishes. And we end up relying so much more on our muscle memory and on short, simple, easy to understand statements. And so that's why the checklist is a great thing. The next thing, though, is you may have this checklist, but there may be decisions that are dependent. If you do this, then you need to do this. If the answer to this question is yes, then you go this route. If the answer to that question is no, then you go a different route. And that's where we start creating what we call process maps or decision flow maps, which I think all of you are familiar with. And then finally, we sometimes transition into pictograms, right? Into plain language. So that again, if we need an action to be taken for someone who may not understand the language, may not be familiar with even where to find the checklists, at least there's a picture, a diagram of what we are striving for. So let me give you an example, which we are all too familiar with. This is PPE, PPE 101, okay? So the narrative, contact precautions include the use of gloves and gowns to prevent the direct and indirect transmission of disease, da 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 da. I am not going to read that when I need to be donning PPE very, very quickly because there's an emergency. But we have to write it because it's a part of the requirements for our CMS emergency preparedness plan. But my hope is that we are at some point taking this narrative and turning it into a checklist. First thing you need to do is stand in front of the biohazard bin. This is what I'm taking off my PPE. How many people in the general public know what doffing is, though? Really? I mean, that's a point right there that is a great example of how we aren't always clear of what we're talking about. But here's my checklist. I'm going to position in front of the biohazard bin. I'm going to make sure that I take, off my gloves. I'm going to tie my apron, pull the straps down, pull it over my gloves. I'm going, step by step of how do you do this? And making sure that we're doing hand hygiene, et cetera, et cetera. This is great too, but it's pretty long, right? And so do we really have time to even do that much sometimes? The next one would be the process flow map. So when I'm first putting on my PPE, I need to wash my hands first and sanitize them. Then I put on my glove. Then I put on my mask. Then I put on my goggles. My gown, my mask, my goggles, and finally my gloves. And when I'm doffing, taking it off, I do it just the opposite. Okay. That's a really simple, really clear process flow map of how to put on and take off PPE. And then here, it's a little less clear in some ways because I don't have the arrows. I like having the step by step, right? But it's actually showing pictures of what it should look like as you're going through the process. So again, just very simple examples of that evolution. Brian, maybe, or am I on this one?
I can take it. Amy.
Go.
So really, we just want to try to summarize here. Understanding takeaway points today, preparedness and response plans and public tools, they're already out there. You have them. Maybe you've adopted templates from other agencies and then localize them to suit your needs. But understand that a lot of them were built without health literacy in mind. They're generally not useful for that reason, or not as useful as they could be. We've identified 4 very basic tools. There are other tools and resources out there that will help you to start focusing on health literacy more within your preparedness plans. And your risk communications, that's what we were talking about, the CERT course. Shows you how to do public information and communications in a health literate format. We must think about this both internally and externally. I think the emphasis over the last 5 or 10 years has been very much external. This is what we need our partners to know. This is what we need our public to know, our families to know. But remember, when the rubber hits the road, you're responding to that incident within the 4 walls of your facility. And there needs to be a very clear understanding of roles and responsibilities. And then the last one, I would strongly emphasize the development of focus groups or target audiences. They don't need to be engaged all the time. Maybe once or twice a year, you could bring your target audiences together and say, here's some of the messaging we've been working on. Here's some of the updates we've made to pieces of our plan. Here's some messaging that if we have say you have a common threat due to the geography of where your building is located, we know that flooding is going to be a very common thing that we're going to experience. So maybe you have a flood toolkit that is prepared and ready to go. Once or twice a year, bring those target audiences in and say, here's some of the updates we've made to these. Does this stuff make sense to you? And believe me, the public is going to be brutally honest with you. And they're going to give you very good feedback in terms of how you can make those tools more helpful. And it's becoming more and more of a best practice for disaster response and communications and health literacy.
So that kind of sums up this topic. I'll go to the next slide because I know there's more from Superior Health. But again, please feel free to reach out to myself or to Brian if you have any questions about this topic. Otherwise, we would be open to looking at questions. Either unmute yourself or type them in the chat, and we'll try to address them today.
Yes, you can hit *6 to unmute yourselves. Please do so and ask any question you might have. I don't see any in chat. Any of my colleagues seeing? I didn't notice any questions in chat.
Well, this is Tony. I don't see any either, but this was absolutely such a fascinating presentation. I learned a lot, and I'm sure that our participants learned a lot too. And I thought that was a great tool. We'll have to make sure that we add that to our Superior Health webpage, the tool where you can actually put elements of your document, and it, kind of so it reminds me when I had to do papers in school, we had a tool that we could use to, that would help us kind of look for different things and make improvements. So that's something that I think was really amazing that I would think would be very helpful to folks. So thanks for sharing that.
Mm-hmm.
Okay, so as you're continuing to think about whether or not you have any questions, I just want to remind everyone that Superior Health Quality Alliance is really interested in helping you out with your emergency preparedness plan. So we want to make sure everybody has one. So if you're one of our community health partners, there's a link on the slides to complete a short 2-question form to let us know how we can support you with that planning. And if you're a nursing home, there's another form to complete. Keep in mind with the nursing homes, we're also reviewing your emergency preparedness plan. So if we haven't had the opportunity to do that yet, particularly the portion that has to do with planning for pandemics or infection control, that area. If you haven't done that yet, keep that in mind. We are doing that for all homes that we're working with. Any questions you might have about this session or anything to do with emergency preparedness, we've got Tony's email address on the slide. Any questions at all? Last chance, if there are. Otherwise,
well, I was just curious if anyone would be willing to share what mechanism or process they use. There was a slide about communicating your emergency preparedness plan, with like residents and family members. And I was just curious how folks are looking at, or patients, how folks kind of have approached that. Is it some kind of like a brochure that you've developed or a one-pager, or do you have newsletters that you share information in? I'd just be curious how folks are addressing that. So I see somebody, O'Brien, that's you that posted, you typically see brochures, okay? Or frequently asked questions, yep.
Has anybody had a surveyor ask to see their communication? Or has anybody been cited? Or been given recommendations on how to improve that communication to meet that requirement? And they're all being shy.
It's the shy group.
Oh, okay.
Let's see, Nancy says we now have a mass communication tool, otherwise FAQs. It's great.
So sort of the mass notification system, like a send word now, or you punch in the message and it gets pushed out to like a distribution list. Yeah, lots of facilities are going that route.
Yep, Code Red is another one. There's a lot of them.
Yeah, and the surveyor that we had this week did ask about that. She asked for a phone tree, if we had a phone tree. And I wasn't actually present for the survey. I was teaching a hospital incident command course, but our director said that she was asked that question, and for a moment she could not figure out what she was talking about. She's like, phone tree, what do I, phone tree? And then it finally dawned on her that she was talking about our mass communication, which we currently use, and we're in process of switching to Informacast. And so, yeah, the surveyors were here this week and they did ask about that.
Yeah, and hi, Mark. Thank you for your volunteering that information. So, you know, I want to distinguish, though, there's a difference between a communication plan and what I believe the surveyors are asking for in tag 35, which is E35, which is that you have to be able to talk about your emergency operations plan with your clients or patients and families. That's a different question than how do you communicate with them. They're both important, but I do think there's a little bit of a nuance there. But I'm glad that Candy was able to find what she needed for that survey. So I recognize voices.
And I recognize that it can, if you haven't gone down this road yet, it can be overwhelming just to say, how are we going to make a brochure for every possible scenario that could happen? My answer to that is don't. Look at your HVA. Look at your top 5 threats on your HVA and build brochures around, here's what we are going to do if any of these top 5 things happen. If you really look at it from a family standpoint, the things they're most concerned about is an infectious disease outbreak, whether or not they have the ability to come and see their loved one, and if there's going to be an evacuation or what happens during a fire. So again, think from the perspective of the families. What are they going to be most concerned about? That's what I would be building my brochures off of. And the last thing that kind of popped into my mind as Mark was talking there is, let's just face it, there are times when we are going to have to tell our families, we're going to have to communicate information that we don't necessarily want to communicate, or difficult information in communication. That doesn't mean that we bury it. That doesn't mean that we don't communicate it. But my recommendation would be, when you've brought it down to a health literacy level to which you can't take it any further, and it's still tough information, always include that empathy statement into your messaging. And what we found is that really de-escalate the recipients of those messages and allows them to internalize that information and recognize that, hey, this agency really is doing the best that they possibly can for my loved one, even in spite of either this difficult message or this difficult scenario. So when in doubt, empathy statements are always helpful to allow people to interpret information.
Yeah, and if you ever have a chance to do an in-person CERC class, it's a 2-day class, I believe. Or maybe it's just one long day, but anyway, it is a great class. And there's, components to it that give you examples of really big failures in crisis and emergency risk communication, and then also some really great wins. So it's a worthwhile class. And Mark is saying that the surveys that were here last week did ask to see their HVA, their hazard vulnerability analysis, and their drills from last year. And I do know that the surveyors are asking to see those drills because any of the waivers or exceptions that were in place during COVID are no longer there. And so you have to demonstrate that you have done these exercises or these drills. And if you don't have them in place, you will get that citation that you need to rectify it. So I'm glad you did it. And they wanted to see the sign-in sheets. Yep, you have to demonstrate who was trained. So make sure you're keeping lists and making copies and putting it right into your plan so you have it available. Well done.
And that just kind of is a nice segue. So we have some exciting news that you'll be hearing, more about, like probably in, June, July, August. But we've invited Amy and Brian back for another 4-part series in August about how to develop your own exercise and training programs. So how to design them, how to write them. So that will be weekly in the month of August. And then the thing that I'm like over the top excited about is that we are busy working on an opportunity for it, and this will be for nursing homes only, to participate in an actual virtual exercise event. And we'll have multiple opportunities. We won't be able to accommodate everyone, of course, but it will be a nice opportunity if folks are looking for, a tabletop exercise to participate in. So stay tuned for more information, probably in early to mid summer. So we're very excited about that opportunity and to continue the journey on just kind of helping to support folks in their emergency preparedness planning. So thanks.
Yeah, and then on that same theme, our next webinar in this session will be on April 20th, and that will be on succession planning. So I think that'll be really, really great too. A reminder that we really would appreciate it if you'd fill out the evaluation that's been posted a couple times here in the chat. We really do use that information, so would appreciate that. And I think unless there's any questions left, we're good. Thank you again, Amy and Brian. This is, again, really wonderful information. We appreciate you sharing it with us.
You are very welcome. Thank you for the opportunity.
Yes, everyone have a wonderful rest of the day, and thanks for attending.